la plática del doctor Platteau se llama HCG, progesterona y LH durante la estimulación ovárica. La buena, la mala y la fea. El doctor Platteau es de origen del país de Bélgica. Su formación educativa fue al principio en Bélgica y después salió, como ustedes pueden ver ahí, en la Universidad de Durban y después en Newcastle, en el Reino Unido. Después fue a Australia y regresó a su país de origen a trabajar. Es investigador, como se ve también en la diapositiva. Es autor en muchos trabajos internacionales, en libros, en artículos de revisión. Ha ganado muchos premios y pues ahora es nuestro ponente, el cual desarrollará este tema que les comento. Doctor Platteau, bienvenido a nuestro congreso.
Thank you very much, Mr. Chairman, and I must congratulate everybody who is here to be so many people here, as there are many very nice alternatives outside. And I must also thank Ferring for sponsoring me to come to this very nice place here in Cancun. I am working in Brussels, in Belgium, and as you can see there, this is our university hospital, and this is our IVF unit. This is where we do now around 5,000 IVF cycles a year, and where in '92 the first ICSI baby was born, a technique which was started in our unit and then went all over the world. For people who do not know Belgium, well, I'll just show you a little bit. This is a very small country, as you can see over there. The star there, this is Brussels, where I work. And if you come from Germany and you drive very fast, you might miss it, because in half an hour you pass it. It's a very, very small country. Now, being a very small country, over all the years before, we were invaded by all our big neighbors. We first had the Romans with Julius Caesar, who came over. Then we had the Vikings from Scandinavia came over and occupied my country. We had the Dutch, we had the Austrians, we had the Germans not so long ago. And we are very, very glad that the Spanish people, with all respect to the previous speaker, came to invade my country. Because thanks to the Spanish people, and also thanks to the Mexican people, we have a beautiful thing in my country. And this is what I want to show you. This is the cacao bean. And long time ago, when we were occupied by the Spanish people, they were also occupying this place. And one Spanish soldier, I suspect he was punished. He had to come from here to Belgium, and he took one of these beans with him to Belgium. The Spanish people were not so interested in this. We Belgians, we like this very much because the stomach is very important for us. And since then, we have the best chocolate in the world. And this is thanks to the Spanish and the Mexican people. And luckily we have this. You see that occupation is not always bad. And thanks to this, we have a very good export product, and we also have a big crisis in my country. There you see one of these best chocolates. You have to be a little bit careful, because of these chocolates who are wrapped in paper, they contain also alcohol. And if you eat a lot of chocolates, you get drunk. Of course, it's not only chocolate, we're also very famous because of the beer. We not only drink Corona, we also drink the Belgian beer. And we have 250 different Belgian beers. And this is what we drink every day. Again, you have to be, when you visit my country, you have to be very careful because these beers, this is one which I like very much. This is about 9% alcohol for one bottle. It's like wine. So if I drink 2 of them, I'm not speaking anymore for the rest of the day. So you have to be a bit careful. So now you're going to say, people drink alcohol there, beer, they eat chocolate all the day. How do the people in Belgium look? Well, these days, all the women, and I'm talking about the women now, they are born with a tennis racket. And these are the best, were the best female tennis players. They are both pregnant now. And Kim Kleisters is a famous example that even being a mother, you can go back to top sport and win Grand Slams, which is a nice example. But of course, you're all waiting to see how Belgian men look. Well, that's very easy. You look at me. I'm a Belgian man. We all look like him. And he's the most famous Belgian man that we have. And we all are like him. Of course, I'm not coming here to talk about Belgium, although I have to sponsor my economy. I'm talking about gonatrophins. But before I want to say something about gonatrophins, I want to start with a little history, a little story. And this is not a Belgian man. This is not a Belgian man at all. And Mr. Chairman, I will not go into politics, but this is an American, and this was the first American president, George Washington. And George Washington, at the end of his career, he got sick. And this is a true story. He got fever, he got pain in his throat, and he was a rich man. He could afford the best doctors from the country to come and visit him and to see what was his problem. And they came, and they said, George Washington, you have a throat infection, tonsillitis, which was right, they were accurate. But at the time of George Washington, the medication, the treatment for tonsillitis was bloodletting. And here you can see the instruments they were taking. Here is the knife, the collection of the blood, and this is what they did in these patients. And that's what they did to George Washington, evidence-based medicine at the time. Tonsillitis means you take blood and then you feel better the next day. They did this to George Washington, and the next day George Washington died. Officially because of the throat infection, unofficially because acute cardiac failure, because they took 2 gallons of blood from him. And this was medicine so many times, so many years ago. And you can imagine that people did not trust doctors, did not want to go to the doctor, because you see what happened to George Washington. But I have to say that these things have changed now. And I will prove to you that these things have changed in an enquete. This is something that's been done every year, and a journalist goes in every country. I didn't find Mexico, but I put Belgium, Switzerland, Italy, and US. And they asked to the people in the streets, how much trust do you have in certain categories of professions? And they ask about lawyers, managers, priests, politicians, journalists, and doctors. The black ones are the doctors. And you see how much trust patients now, these days, have in all these things. And in every country, and I'm sure in Mexico it's not going to be different, you see that we, our doctors, are doing very well. We're doing the best in all the categories. Meaning that people, patients now, they trust us. They trust us that we're not doing like in George Washington. We give a treatment because we heard and maybe it will do. No, we have treatment based on evidence-based medicine. We compared drug A with drug B, and we saw that drug B is doing better than drug A, and we go to drug B. And it's simple as that. I like this slide very much because my father is a politician. And as you can see, the yellow is the politicians, and I showed him how the politicians were doing in Belgium. Again, Mr. Chairman, I will not go into politics. I just wonder how the politicians in Mexico will score here, but I suspect it's going to be exactly the same. But anyway, I'm talking about gonatrophins here, and this is a little bit the story about this evidence-based medicine of gonatrophins over the last 20 years. And as you can see, this is the meta-analysis of all the randomized controlled trials on these gonatrophins. And the first meta-analysis was published in 1995, it was Salim Daya, and there they compared the recombinant, the pure FSH, with other gonatrophins, and they saw that pure FSH was the best in live birth rate. Then in the 2000s, some more meta-analyses were done, and there they saw that if you used pure FSH or HMG, there was no difference at all in live birth rate. You just wonder why this happens in one thing to another. Well, it's very clear. Here, the studies that were involved were studies a lot from the 80s where there was no suppression at all. No agonist, no antagonist, with just natural cycle or some stimulation. And you can imagine that we're not doing this anymore. The more studies came with long protocol in the 90s, the more these early studies were buffered out and there was no difference at all anymore. And then the latest one here, it shows that the HMGs are superior to FSH, pure FSH, rec FSH, and even the last one is one where they used the menotropins, and it showed that there was superior in favor of the menotropins. Why this change here? Well, these people here, they said, look, in a meta-analysis, there is no point to use studies where there is no suppression. These days, we use long protocols with agonists, we use antagonist protocols, we do not use any more protocols where we do not suppress at all. This is the day-to-day practice. So all the old studies were taken out, and there is the reason for the change in the live birth rate. And here you see it again. Now, this is one of these meta-analyses that we had lately published, and it's all very nice. The only problem that I have with this meta-analysis is that they're talking about HMG versus recombinant FSH, and they say these HMGs are all the same. I believe they are not the same. There were used Humegon, there were used Pergonal, Menogon was used, Menopur was used, and I believe that these menotropins were not the same. These HMGs are not the same. And why are they not the same? Well, here you see they are different in this beautiful molecule, and this is ACG. And this ACG is so nice, and it's very similar to LH, apart from this carboxy terminal peptide here that gives it a very long stability. And the previous speaker already talked about colitrophin alpha. There again, this CTP was put on the FSH to give it a long half-life. And this is the reason why the half-life of ACG is about 40 hours and the half-life for LH is about 20 minutes. Meaning if you give an injection of LH, after 1 hour, it's completely gone. If you want to give LH, fine, but then you have to give an injection every hour. And why making it difficult when you have a product that stays for more than nearly 2 days? And where is the difference in these products? Well, here you see, when you look at Menopur, which is Merapur here in Mexico, it contains, of course, FSH. It does not contain any LH. It contains 10 units of ACG. So every 75 units of Merapur contains FSH and 10 units of ACG. Before Pergonal, Humegon, you see the differences in the ACG and LH. And of course, a recombinant does not contain any LH any ACG, it just contains FSH. And the very nice thing here is that if you compare this one with this one, you just make the difference in this one. And that makes it very interesting in research. And I will show you a few studies. Here, there are the studies where they compared the preparation which contains ACG with the preparation which does not contain any ACG. These are the studies, 1,500 patients, randomized control, evidence-based. And here you see the live birth rate when you compare this, and it shows that the live birth rate is doing better if you give an ACG preparation as a stimulation to your patients in a long protocol compared with a recombinant FSH preparation. And this, okay, we say this is long protocol. Now in Mexico, apparently nobody uses long protocol, everybody uses antagonist. Fair enough. These are the studies from the antagonist. The first one was done by Ernesto Bosch from Spain, and he compared again the same study, an ACG preparation with a recombinant, and the results were exactly the same, although this was a little bit higher, but not significant. And here you see always the same story, and I will come back to that. When you compare this ACG preparation with an FSH-only preparation, you get more oocytes in the FSH preparation, you have a higher progesterone in the FSH preparation, and you have a lower estradiol level. And this comes back every time. Less oocytes here, and usually a better pregnancy rate. And going back to the latest study, this is the Megaset study. There again, an antagonist cycle where 150 units of menopur was compared with recombinant FSH. A very beautiful study where a single blastocyst was transferred. And when you see the results, this is the number of oocytes. Again, when you use the ACG preparation, you have 1.5 oocytes less. But when you look at the pregnancy rate, there is always a trend towards a better pregnancy rate in clinical pregnancy rate, ongoing pregnancy rate, when you give this ACG preparation. And this is all very nice. And these are the data. Some people like this data. Some people do not like this data at all. But I'm very sorry, this is the evidence there. And if you don't like it, well, there are some tablets. You take a few of these tablets, and after a couple of days, you feel better. But what I think is more important is to find out as a clinician, why is this? Why on earth do you get a better pregnancy rate when you give some ACG during the stimulation to your patient compared that you don't give it? And I think this is much more important to understand what is happening. And I want to come to the frozen cycles. I always wonder when we have a patient, beautiful embryos, fresh embryos, we do the transfer, no pregnancy. 1 month later or 2 months later, we do the frozen transfer, we put 2 embryos, twin pregnancy, everything is going all right. Why is this? Why with the fresh transfer, where the best embryos are transferred, it does not work? And then in the frozen, where per definition embryos were not so good as in the fresh one, they implant and give the twin pregnancy. Well, it may be that the first gynecologist in the fresh cycle did not do the transfer very well, but we all very good gynecologists, so this is out. It might be the embryologist who made a mistake and took the bad embryos first and then the good embryos for the freezing, but we have all the best embryologists, so this is nothing. Or we did something to the endometrium during the fresh stimulation that changed the endometrium, and then in the frozen cycle, where we do not do anything, it's a natural cycle, we have the pregnancy. And I think there is the reason for these things. And I want to talk about progesterone, because I believe that this progesterone is the bad guy, is the one who makes these differences. And here you see the differences when you stimulate with an ACG preparation compared to a recombinant FSH on the day of ACG and on the day of oocyte retrieval in progesterone levels. And you can see that the progesterone levels are significantly higher if you do not give an ACG preparation. And is this bad, this progesterone? Well, I want to show you a few slides to show you that this progesterone, in fact, is bad news during the stimulation. Here we took from the MERIT study all the patients and we divided them in progesterone low at the day of ACG and progesterone which was high. And you see, although the patients who had the high progesterone on the day of ACG, they had about 4 oocytes more. They had a lot of embryos, top quality, but the pregnancy rate was nearly half of the ones who had a low progesterone. So it's very clear that this progesterone does something to the endometrium, that we miss the implantation window and we put beautiful embryos somewhere where it is too late. And here you see also the Spanish group from Ernesto Bosch again, who did a retrospective study, and they showed clearly that once you have a high progesterone over 4 nanomole, you clearly have bad news for your pregnancy rate. And I think it's clear that progesterone is the bad boy and that you should avoid this. Even a later study, and this is a Chinese study, and that was even cleverer, they looked at the number of days the progesterone was high. And you see clearly, the more days you have a high progesterone, the lower the pregnancy goes. In a short protocol, an antagonist protocol, a long protocol, it does not matter. The more you have long progesterone, the worse your pregnancy rate. And here, according to the number of oocytes, exactly the same. The more progesterone days, the worse is your result. Now, this is from the MERIT study, and this is patients who had 1 top quality embryo transferred, either by stimulation by recombinant FSH or by a preparation with ACG. So a beautiful embryo, the same, the embryologist euphoric, and we put it back, and it seems that more of these top quality embryos implanted when you gave an ACG preparation than if you gave a REC FSH preparation. And I think the reason for that is, again, probably this 20% or 10% of the patients, they had a high progesterone, the implantation window was gone already, and we were too late to implant the embryos. Now, this is what happens normally in a natural cycle. And this is the progesterone, and of course, during the natural cycle in the follicular phase, the progesterone is very low, and then at the end, it creeps up a little bit, you have the LH peak, and then the progesterone goes up. At that time, there are some endometrial changes. They get luteinized, and then we do the transfer, or we have the implantation. What we are doing with our stimulation is that this thing that's happening here is not happening there anymore, but it's happening here. Long before we do the stimulation, we could do the transfer, or we do the pickup. And what happens is that the implantation window where we transfer here is long gone. We have beautiful embryos, and we put them in an endometrium which is not prepared anymore, which is screwed up by our stimulation. And this is a slide just to show you where is this progesterone coming from. And we in Brussels, we are paranoid about progesterone. And the progesterone is coming mainly, and this is the 2-cell 2-gonadotrophin theory, you all know. You have the granulosa cells, you have the theca cells. FSH, which stimulates the granulosa cells, stimulates the production from cholesterol in progesterone. And this progesterone cannot be converted into androgens because the enzyme is missing, and it diffuses and comes into the blood. Meaning that the more you stimulate the initial dose of FSH, the more you're going to produce progesterone. So if you start giving dosages of 300, 375, 450, you're going to stimulate the production of progesterone and make the progesterone going into your patient very high, which I think you should not do. The other part of the progesterone source is from here, and this is under control of LH. Cholesterol is converted in progesterone, and under the influence of LH or LH activity, this progesterone is converted into androgens, which then go to the other side and are aromatized in estrogens. And this is the reason why if you give a preparation which contains ACG, at the end you have a much higher estradiol level, because these things are converted into estradiol level. So what you should do to get very high progesterone is to stimulate with a very high dose of FSH and do not give any LH activity. You're going to be sure the progesterone is going to be very high. Now, this is all very nice, but we are all clinicians, and what does this affect our daily practice? You all see your patients, you do the ultrasound, you take blood, and you decide the stimulation to increase the dose, lower the dose, etc. This is a long protocol, and I say this is what we do in Brussels. And we are paranoid about this progesterone. And so in a long protocol, the patient starts with the agonist. Before starting with the gonadotropin, with the stimulation, we ask for a blood test. First to see estradiol, if it's low, fine, usually there's no problem. But for progesterone also. If the progesterone is high here, we do not start the stimulation. Because if it starts high here, after stimulation, you're going to be a very high progesterone level, your endometrium is going to be changed, and you're going to miss the pregnancy. So what we do is progesterone high, okay, we continue with the stimulation. Sometimes it happens. The luteal corpus luteum from the previous phase is still producing some progesterone. In a few days, you see it going down, and there is no problem. Some patients, this is not very frequent, but it happens, they continue having high progesterones because it comes from the surrenal gland production. And in these patients, with a small dose of dexamethasone, you suppress the production of surrenal production of progesterone. After 2-3 days, progesterone goes down, and you can start the stimulation. But we will never start if the progesterone is not low here. And then after 5 days of stimulation, we check again progesterone. If the progesterone after 5 days is very high, it means we got it wrong. It means we started with a dose which was too high. You remember the granulosa cells, the FSH is producing the progesterone through the cholesterol. We had it wrong, and we reduced the dose. It's amazing, you can see it. 1 or 2 days after you reduce the dose, you measure the progesterone goes down. It's just this stimulation from the granulosa cell that goes away. And then further on, we continue doing blood tests for progesterone. And once we see the progesterone, and this is normal, at the end of the stimulation, with a lot of follicles, the progesterone goes up. Once we see it's creeping up, for us it's time to finish the stimulation, to give ACG, and to do the pickup. More according to the echo, we follow the blood test and see the progesterone is very low, we are calm, we can continue a bit longer. If it's too high, we stop it, it means it's finished, we have to do the pickup. And this is what we do in our day-to-day monitoring in Brussels. Of course, you're going to say, in Mexico, long protocols you don't do anymore, it is antagonists. We do this also. And this is our antagonist protocol. And of course, in the antagonist protocol, we had a problem. With an agonist, if the progesterone is high, you can just continue the agonist and you wait till the progesterone is down. With the protocol with the antagonist, on day 2, normally you start stimulation. If the progesterone is high, you have to start, because otherwise you lose a month, patient will go to the other competitor center because he didn't start, and you lose them. This is life. So what we did, and the reason for that was initially just because of our paranoia of the progesterone, we started with an antagonist on day 2 of the stimulation. And day 2, day 3, day 4, we give an antagonist, and on day 5, we check for progesterone. And usually, after 3 days of antagonist, estradiol is very low, LH is also very low, and the progesterone is low. If it's not low, we continue a bit longer, but this doesn't happen very often. And I think this is a reason. You remember the first meta-analysis of antagonists towards agonists. The antagonists were not doing so well compared to agonists. I believe the reason for that was that when we start on day 2 with the stimulation, a lot of patients still have a high progesterone from the previous luteal phase. And then you start a stimulation with a high progesterone, it just goes higher and you lose your pregnancy. If you do this, you don't have this problem. And we saw a lot of advantages of it. First of all, I do work in a lot of private practice. I get the phone calls from the patients and they say, "Doctor, today is day 1, but is this day 1 because it started bleeding at 7 o'clock in the evening? And the bleeding is not much, it's just a little drop. Is this day 1? Is tomorrow day 1? You know, all these phone calls and you don't know what to say. With this thing, we don't have a problem. We just say, start with the antagonist, in 3 days' time they have a proper period and it's sorted and it avoids a lot of stupid conversations about each thing. And what we also saw that, and this is not medical, that by giving this antagonist here, we could plan to go to Cancun for a conference and avoid to do the pickups on the day that we are in Cancun, because you can just organize with the antagonist. And there were more interesting things that I will show you later on. And then further for the stimulation, we do like a total long protocol further on, always paranoid about the progesterone, and we induce when the progesterone is high. Now you can say, okay, this is all very nice, all very big, but where is the evidence? Well, we did a study in Brussels to show this protocol compared with the standard protocol where we don't do this. We call this the sandwich protocol now, because it's like a sandwich with the antagonist. And it's Christophe Bloquel who did this study, and I must say there are about 70 patients involved. Pre-treatment is the sandwich, first 3 to 5 days of antagonist, and this is the control group, the usual routine antagonist. And as you can see, when you do this pre-treatment, the number of oocytes is 4 oocytes more. And we were surprised. And we also got more hyperstimulation with this pre-treatment. And the reason for that is quite logic. When you use this protocol, it is like a long protocol, but with a treatment of 3 days, because the antagonist in 1 day, it switches off. You don't have the long protocol with flare up and then goes down. It goes immediately. And it's like doing the same thing in a long protocol. And the other advantage that we saw was that in an antagonist, where you have the stimulation first, 1 wave of follicles, and then a second wave of follicles, when you give this pre-treatment here, you have all these follicles who want to start in the beginning, and they all go much nicer together, and this is resulting in many more oocytes, and also much more risk of hyperstimulation. It goes together. And as you can see, more oocytes, more embryos for freezing, and then the results, and these are good patients. These are patients that had first or second cycle. You know, a study, you want to make publicity, like we are the best in Brussels. Well, this is to show the things, but this is not what it's the usual thing. And here you show that implantation rate was 42, pregnancy rate was in the 40s, 50s, but you see nicely that the pre-treatment group is doing much better, even in pregnancy rate, than in the non-pre-treatment pre-treatment group. And this all comes because of our paranoia for the progesterone. Just to show you a last slide to convince you about ACG. And this is from the MERIT study. And in the MERIT study, we took, after 5 days of stimulation, we took blood for ACG. So these were patients who had 225 units of menopur every day. That means 225, 30 units of ACG every day in their blood. And you can see after 6 days, some patients had nearly no ACG, and some patients had a lot of ACG in their blood. And there was a clear correlation between the pregnancy rates, and this was significant. So the patients after 5 days of menopur who had the highest levels of ACG, they had the highest chance of being pregnant. And then we looked at it, why is this? Because everybody received 30 units of ACG. So why this one has no ACG anymore and the other one has MESH? Well, it is like, we thought first the big ones are the ones here and the small ones are there. Nothing to do with body mass index at all. It's like for the Belgian beer. When I go out with my friends and I drink Belgian beer, 2 beers and I'm out. My friends, when they drink 2 beers, they still do not feel anything. It's because my liver is not metabolizing the alcohol very well, and my friends, they do. With ACG, it's exactly the same, but it's the kidney who gets rid of the ACG. And some patients are secreting the ACG very quickly, and some do not, to their advantage, because they get a better pregnancy rate. And I think in the future, it might be very interesting to get preparations, not only with 10 units of ACG, but with much higher content of ACG, so that these patients who are here, we can bring them in this category and increase the pregnancy rate. But I think this is for the future, but there's been work on that. So, Mr. Chairman, in conclusion, I think there is the bad one, there is the good one, and the ugly one. The good one, I think, is very clear, I showed in the last slide, is ACG. The bad one, we are paranoid about him, is the progesterone. And the ugly one, I think, is LH. Because LH says, I am like ACG, but in fact, he's not. He's a very short half-life. And I think this is ugly. Thank you very much.